So my name is Brendan Delaney. I'm chairing medical informatics and decision making at Imperial and the lead for workstream 3. We're going to have 3 short presentations. First of all, Johnny Clarke and Prociuk, and then Nikki Smith, who's going to give a patient view on this. And then we'll have a discussion session, which I hope will be quite entertaining. And if people want to either put their hands up, since we're a relatively small group, or put the question in the chat, then I'll moderate that part. So, Johnny, over to you.
Great, thanks, Brendan, and thanks to all of you for joining today. As Brendan said, we're going to go through quite a few different things over the course of this webinar. Starting off with trying to consider how we go about using routinely collected healthcare data to identify patients with the diagnosis of long COVID. So we know that long COVID is common. We know that from some surveys that have come out relatively recently from the USA that as many as 7% of adults surveyed have reported symptoms consistent with a diagnosis of long COVID. And in the UK, from the Office of National Statistics, again from 2024, you can see that as many as 3.3% of adults have self-reported symptoms consistent with a diagnosis of long COVID. So it's very common within the population of the UK and the USA. But it's potentially quite challenging to go from that common population prevalence or assumed prevalence of self-reported long COVID towards identifying these diagnoses from within medical records. So again, in work that came out earlier on this year, only 14% of patients with a previous COVID infection had reported long COVID symptoms, or at least symptoms that were consistent with long COVID. But of those, only 5.4% of those who had long COVID symptoms had a long COVID code in their patient record. So only 1 in every 20 patients who had self-reported long COVID had a code in their primary care record. So there's a significant undercoding. And researchers have tried to look at that through using different methods to identify patients with a diagnosis of long COVID within various health data sources. So this study from Scotland, again published earlier this year, showed that when looking for clinical codes, so that is numerical sequences that are recorded in medical records that indicate a condition, only 0.02% of people in Scotland across this national study had a diagnosis of long COVID recorded. If instead you used free text, so the typed notes that GPs had entered into a clinical record to identify patients with long COVID, then you would find that 0.2% of people had long COVID. Alternatively, if you looked at the diagnoses or the text recorded in sick notes, you'd see that goes up to 0.3%, but still very, very low. And then finally, if you use a definition that is based on symptoms that patients have had recorded in their medical record, and also other patterns of interaction with health services, particular types of appointments and referrals, you still only get to 1.7% of the Scottish population as having a long COVID diagnosis. So however you choose to go about identifying patients with long COVID, there's still tremendous under-recording. And also within these various methods that we use to identify patients with long COVID, there was really very little overlap in terms of patients that were picked up by one method and picked up by another. So can you still see me sharing the screen? Yeah. So 4.5% of those who had code for long COVID in their primary care record also had a mention of long COVID in the free text of their medical notes. So actually very little agreement there. You'd expect that to be near enough 100%. And similarly, of those who had long COVID recorded on a sick note, none of them, or next to none of them, had long COVID also recorded in their medical notes as a clinical code. So there's really very little overlap. It makes it very problematic in comparison to an analysis on, for example, type 2 diabetes, where coding in the primary care record is generally very good. It means that you can use electronic health record data, you can use primary care record data to identify conditions far more straightforwardly. In the case of long COVID, this is far more complicated. And so we were working primarily from primary and secondary care record data, so GP records and hospital records in Northwest London. And this graph here shows the number of new people who had a recorded long COVID diagnosis in their primary care record over time, beginning at the start of January 2020. And you can see that we get very, very little activity up until the start of January 2021, when codes for long COVID started to appear in the primary care record. And you can see that over time, the type of code that's being used has changed. So if you only use one code, if you only use this purple code, post-COVID-19 syndrome, initially you'd be picking up most people who had received a long COVID diagnosis. But then later on, you'd be missing out all of these people that were other colours that were recorded under a different code. So it's a very complex picture, as opposed to other conditions where there's perhaps a more stable coding practice over time. And this made it quite challenging when it came to identifying which patients in Northwest London had a long COVID diagnosis. And then we wanted to also look at the extent to which the different sources of information about long COVID that we had access to agreed with one another. So we had access to 3 different information sources that we could use to potentially identify patients with long COVID. Firstly, we had the primary care records that had the presence or absence of a long COVID diagnosis code, so a numerical sequence that indicates someone has a diagnosis of long COVID. Separately, we had records to indicate whether someone had been referred to a long COVID clinic. And finally, we had whether people had attended a long COVID clinic. And you can see here from this Venn diagram, and these numbers are indicative, they've actually changed a little bit since then. But what you can see is that the majority of people have only a long COVID diagnosis code in their primary care record, rather than necessarily having attended a clinic or been referred to a clinic. And this, again, suggests quite a complicated picture. So it'd be easy to say, okay, well, just take all of those patients that have a long COVID code in their primary care records, and those who have a referral code, and those who've attended a clinic, and treat all of them as having a long COVID diagnosis. But that's probably an oversimplification in the sense that you don't need to have a referral to receive a long COVID diagnosis. Not all referrals lead to a long COVID diagnosis. And finally, attending a long COVID clinic doesn't necessarily lead to a long COVID diagnosis, because you could have another condition aside from long COVID, but despite being referred to a long COVID clinic. And from the data that we have, only 4.4% of the whole population that we looked at that had a long COVID diagnosis or any sort of activity had all 3, had a referral, a clinic attendance, and a long COVID diagnosis in their primary care record. Over half of them just had a long COVID diagnosis as a code in their primary care record. And if we think about those that were referred, only a third had actually attended a long COVID clinic or had a recorded attendance. So it's a very patchy data landscape when it comes to answering a relatively simple question of who's got a long COVID diagnosis. So there's no perfect solution, and whatever you do, you're going to be missing patients. So we were left with trying to come up with the best balance between identifying as many patients as we could with a long COVID, who had long COVID, while also ensuring that that population are likely to have long COVID, rather than picking up other things besides that. And therefore, we're left with a relatively simple definition that definitely misses patients, which was to just focus on patients that had a long COVID diagnosis code recorded in their primary care record. And in the work that Dennis will present in the next few slides, we go into that in a little bit more detail. But that's the case definition that we've used. And it's imperfect, but I'd welcome any questions on what you make of that afterwards. So Dennis, over to you.
Thank you. So I'll be talking a bit about how the patients who actually had one of those SNOMED codes that we use to identify them, how they actually sort of looked from a demographic and clinical perspective, and comparing that to the general population within Northwest London, as Northwest London was our data set for control. So on the right, you can see the actual odds ratios indicating how each of these parameters makes it more likely that a particular patient does end up with one of those SNOMED codes for long COVID. And what we found is that a typical long COVID patient would be slightly older, with a bit of a caveat around the particularly old age groups above 71 to 90, with the age group between 41 and 70 having significantly higher likelihood of receiving long COVID diagnosis. Likely female, just sort of aligns with a lot of the other studies that come out. But something that the two parameters that we found were perhaps slightly disagreeing with some of the studies that were published and might be counterintuitive were around deprivation scores, where you can see with IMD quantile, where we found no strict relationship between deprivation and likelihood of receiving a long COVID diagnosis, as opposed to some of the other studies that were published, as well as ethnicity. There have been a couple of previous studies that mentioned that perhaps ethnic minorities are less likely to receive long COVID diagnosis, but what we found within Northwest London is that the likelihood is actually higher, which might be linked to a number of things, as for example, key workers. The ethnic minorities are overrepresented within key workers in Northwest London, which could account for perhaps multiple numbers of COVID infections that led to a long COVID developing, or perhaps it's something else to do with the makeup of our data set. We also looked at the presence of chronic conditions over last couple of years before the COVID-19 pandemic began, as a baseline for looking at how the clinical profile of a typical long COVID patient would look like. And we found that a couple of conditions were highly indicative of developing or receiving a long COVID diagnosis, especially anxiety, asthma, eczema, depressive disorder, and hypertension were especially correlated with sort of lighter correlations with things such as chronic kidney disease and diabetes. What we've also considered is that these conditions might be clustered together, where perhaps a patient with one of them would develop conditions that are related to the same organ group. Especially, we can see this a lot, especially in patients who are older, where multimorbidity becomes a real problem for health management. And we've done work on clustering these conditions using K-means clustering, and found that they do cluster around organ groups. So, for example, asthma, COPD, and chronic lung disease all cluster together in the patients that we're looking at, as well as mental health conditions. Also, so anxiety and depression were particularly closely tied together. Following that, Johnny, could we go? Oh, thank you. We considered not only just how likely they are to receive a long COVID diagnosis, but how long it might take for them to receive this diagnosis. It's complicated to decide what triggers a long COVID diagnosis in terms of a COVID infection, as throughout the pandemic, people were infected multiple times with sporadic testing and reporting of those COVID tests. This makes it very difficult to assign a confident time interval from infection to developing long COVID, which is why we've gone for January 1st, 2020 as a catch-all for all of the patients that we had in our dataset. This means that what we're seeing on the right side with this graph is the average amount of days that it took for a patient to get diagnosed with long COVID after 1st of January 2020. It's a pretty significant assumption, but I think we can still find some very interesting results based on our analysis, particularly that this group of 41 to 70, which we saw in the previous slide, is more likely to receive a COVID diagnosis in the first place, is also more likely to receive a long COVID diagnosis earlier. You can also see that ethnic minorities are also more likely to receive it slightly earlier by a factor of about 20 to 30 days. Strangely, curiously enough, women are more likely to receive a long COVID diagnosis later, despite representing a significant portion of the patient group, indicating that perhaps there's some underlying reason in terms of the condition not being taken seriously. We can also see that with the one chronic condition where we found a significant correlation between the time to diagnosis, and that's depressive disorder, with other chronic conditions giving us wide confidence intervals, not us being unable to say anything confidently about that. But depressive disorder did show that there is a statistically significant delay in receiving a long COVID diagnosis, which is especially troubling given that both anxiety and depression have very high rates amongst long COVID patients, and they also have very high rates of developing in long COVID patients. So on this topic of developing conditions, we looked at how these clusters that I mentioned previously around organ groups, how patients developed new conditions, or which clusters were less likely to develop new conditions. I found that 40% of patients with long COVID did develop some sort of new condition over the course of the last 3 years, with particularly high numbers in anxiety, where it was around 20% of patients with long COVID developed a new diagnosis of anxiety, but also depressive disorder, diabetes type 2, hypertension, and asthma. And all of these rates of developing new conditions were statistically significantly higher than in the general population. Now, there is a question of whether is it caused by long COVID? Is this a consequence of them receiving sort of more medical care? But I think with what we've seen in terms of patients being diagnosed later, if they already had one of these conditions, it's quite worrying that they're also developing them at a much higher rate. And for the next part, we'll hand over to Johnny. Thank you.
Thank you very much, Dennis. So you've seen there that there are significant differences between populations in terms of how likely they are to receive a long COVID diagnosis in their primary care record. But we were also conscious of the fact that long COVID is a condition that can affect multiple body systems, and it can lead to a wide range of symptoms as a result. And when this is occurring as a new condition, while the health system is under significant strain, there was the feeling that the patient journeys, or the steps that patients might need to go through in order to receive a long COVID diagnosis or to receive the treatment that they need, could be quite convoluted. And so with that in mind, what we wanted to do was look at the hospital data that we had to try and see how the interactions with hospitals that our patients that we'd identified with a long COVID diagnosis had before the pandemic, in the period before their diagnosis, but after the pandemic, and also after their long COVID diagnosis. And that's some of the work that I'm going to share with you now. So we started off by taking forwards the 6,000 or so patients that we'd identified as having a long COVID diagnosis in their primary care records, and looked to see how the frequency of attendance in inpatient, outpatient, or A&E departments changed over time. So this is just showing the crude number of attendances on the y-axis for each plot for each week since the 1st of January 2019 up until the end of our study period, which is in September 2023. And you can see that in the case particularly of inpatients and outpatients, at the start of the pandemic, which so lockdowns are indicated by that vertical dotted line, there's a dip in activity. And that reflects the general shutdown in inpatient and outpatient care, particularly for planned care that happened associated with the pandemic. You can see there's not quite the same dip for A&E care, suggesting perhaps that the patients that we are focusing on here, the patients who went on to have a diagnosis of long COVID, still continue to present to A&E with similar frequency to which they had done before the pandemic. And then we can see as the pandemic progresses, as time passes, the frequency of utilization of secondary care goes up in pretty much all cases, but particularly for outpatients, and then to a lesser extent inpatients, and also A&Es remain above the pre-pandemic baseline. So the horizontal dashed line there is an average of the first month, so the month from of January 2019, the first quarter of 2019, just to give you an idea of comparison. So you can see in all cases, utilization is above the baseline across that period. So frequency of utilization has gone up. So since the pandemic, people with a diagnosis of long COVID are using hospitals more. What we wanted to do, building on that finding, is try and understand how that increase in using hospital services related to the date at which each individual was diagnosed, because people were diagnosed with long COVID at different times. As we see from 2021, there's lots of people diagnosed across the period that we're looking at. And so what this chart shows is the frequency of attendance at inpatient, outpatient, or A&E services as a proportion of the number of people. So it's a measure of the number of attendances per 1,000 patients per day. And it looks at the 52 weeks before their diagnosis and the 52 weeks after their diagnosis. So you can see most markedly that there is a peak in activity at week 0. So that indicates that the highest rate of activity for any period in the year, either side of their diagnosis, is in the week at which they get the diagnosis. And this was surprising for us because we hadn't expected such a profound peak. And what that probably means is that an attendance in hospital is the means by which a long COVID diagnosis is conferred and appears in a patient's primary care record. So a patient attends A&E and is seen, and they receive a diagnosis of long COVID, and then the letter goes back to the GP, and then it's recorded in their notes as long COVID and the date of their A&E attendance. The same story for outpatients, same story for inpatients. And clearly that's not always the case, but that's our best explanation for the unusual peak that we see there. What we can also see is that in the case of inpatients, outpatients, and A&E, there's a steady increase in activity in the period before their long COVID diagnosis. And in the case of A&E, after the diagnosis, it returns almost to the pre-pandemic baseline. However, in the case of inpatients and definitely outpatients, activity remains well above the activity that was there before the pandemic and before the diagnosis. So we've got some interesting changes there and some interesting findings that help us shed a bit of light on how a long COVID diagnosis code appears in a primary care record. But what we wanted to do moving on from this is to try and compare how things were for individual patients. So to do that, we looked to divide our data into 3 periods that were specific to each patient. So firstly, we had a pre-pandemic period, and that was actually the same for all patients, that spanned from the 1st of January 2019 to the 31st of December 2019. And then we had a pre-diagnosis period that for each patient was defined as from the 1st of January 2020 up to the date at which long COVID was recorded in their primary care record for the first time. And then thirdly, we had a post-diagnosis period. And in that case, it was from the date a long COVID diagnosis first appears in a patient's primary care record up until the end of the period that we're studying, which is the 30th of September 2023. So for some patients, the pre-diagnosis period could be relatively short if, say, for example, they were diagnosed with long COVID very early on, say, January 2021, as some of the earliest cases we have in our data. Or it could be that they have a very long pre-diagnosis period and a shorter post-diagnosis period, if, for example, they were diagnosed in 2023. So this allows a little bit of flexibility in terms of how we think about each individual patient, rather than just dividing our data into fixed months, for example. And so what we can see from these two charts is, firstly, that comparing the pre-pandemic, pre-diagnosis and post-diagnosis periods, the proportion of care that is to outpatient services, inpatient services and A&Es remains relatively similar. So outpatients are occupying a higher proportion of all activity for long COVID patients in the post-diagnosis period, whereas in the pre-diagnosis period, A&E care sees a bit of a jump in activity that then goes back to below pre-pandemic levels in the post-diagnosis period. So that's relatively balanced there, but what we do see is a significant difference in the number of patients, or the percentage of patients that are attending each service. So if we think about comparing the pre-pandemic period to the post-diagnosis period, 45% of patients in the pre-pandemic period had attended an outpatient clinic in that year before. But in that post-diagnosis period, that rises to 68%, so a big increase. And similarly, thinking about inpatients in A&E, we see that big jump going from 18 to 34% in terms of pre-pandemic to pre-diagnosis for A&E, and going from 25 to 48%, so pretty much doubling for inpatients from the pre-pandemic to the pre-diagnosis period. And that's on this chart on the right-hand side, going from the purple up to the orange. So big increases that then decrease a little bit in the post-diagnosis period. But essentially, summing that up, patients are going to hospital more often after their long COVID diagnosis, or in the period when they were getting their long COVID diagnosis, than in the pre-pandemic period. So the intensity of utilization has gone up. But what we then wanted to investigate was the extent to which patients were attending multiple different specialties or attending multiple different hospitals in order to receive their care. And to do that, we looked at two different things. We firstly, relatively simply, looked at counting the number of specialties that a patient had attended in each period, or counted the number of hospitals, hospital trusts in this case, that patients had attended over each of these periods. And what we see when we look at that is that for clinical specialties, there's an increase, as you can see on these plots here, in patients that are attending a large number of specialties in the pre-diagnosis and post-diagnosis period. So while the median number remains pretty much the same at 2, the tails, so the upper quartile increases, and then the other centiles increase markedly for those in the pre-diagnosis and post-diagnosis period. So that indicates that although the average might not have changed, there is a group of patients that are attending more specialties and for whom the burden of clinical care has gone up. And similarly, we see a similar sort of thing with the providers. Although the median remains the same, in this case 1, so on average people are attending only 1 provider in a given period, we see that the number of people who are attending lots of providers, who are attending 3 or 4 providers in a given period, goes up. We then wanted to understand the extent to which patients going to different providers was in a way that conferred continuity of care or not. So there's a relatively simple measure called the sequential continuity, or SECON measure. And that just measures the percentage of occasions that you attend 2 specialties that are the same on adjacent appointments. Or similarly, the proportion of time, the percentage of the time you attend on 2 outpatient appointments, you attend the same hospital. So we can see that in the case of specialties, so before the pandemic, when patients had outpatient appointments, on average, 44% of the time were they to the same specialty. So it's already pretty low. And then after the diagnosis, that goes down to 40%. So actually a relatively small change, and that's not statistically significant. So continuity of care with respect to outpatient specialties doesn't really change comparing before and after the pandemic. However, we do see a marked decrease, a statistically significant decrease in the sequential continuity at provider level. So we see that the average patient, the median patient before the pandemic, is attending the same hospital 100% of the time. So sequential continuity with respect to hospitals is very high. This goes down to 83%. and we can and that indicates that more often patients are potentially going to different hospitals on successive occasions, which in the context of information not moving well with them could lead to a disruption in their continuity of care and associated difficulties for patients in navigating the system. And then finally, what we wanted to do was understand, having seen these low rates of sequential continuity with respect to hospital specialties, but that didn't really change from the pre-pandemic to the post-pandemic period. We wanted to see if they had changed qualitatively otherwise. So what we've done here is plot a network that shows where patients attend 2 different specialties on adjacent appointments, which 2 specialties were they? So this network here is for the pre-pandemic period. And you can see that there are connections that are relatively strong between trauma and orthopedics and allied health professionals. This is probably physiotherapy following an orthopedic procedure, for example, and radiology connected to trauma and orthopedics. Again, x-rays for various orthopedic conditions. There's also a connection between obstetrics and midwife episodes, again, suggesting that this is for obstetric activities, so people having babies. And what we see when we move over to the post-pandemic period is a fundamental shift. So I'm going to just cycle between the 2 so you can see the difference. What we see here is respiratory medicine becomes a hub. So patients are attending different specialties and then going back to respiratory medicine often. So whereas in the pre-pandemic period, it was essentially playing a relatively minor role in the patient sharing network for patients with long COVID, after a long COVID diagnosis, it plays a crucial role in terms of seeing patients and also potentially coordinating their care, whether that's something that's programmed into the way that they deliver their services or not. Respiratory medicine is seeing patients who've seen lots of other specialties more often. We also see that the connections from respiratory medicine to cardiology are the strongest. They're existing as a relatively strong pair when it comes to providing specialty care for patients with long COVID. And if their communication channels are not well joined up, there could be problems for patients with long COVID in terms of the way that information is shared between specialties. But we also see that respiratory medicine is strongly connected to lots of other inpatient, surgical and medical specialties. And that's in marked difference to what we saw previously. So although sequential continuity hasn't really changed very much from the pre-pandemic to the post-pandemic period, the specialties that patients are moving between have changed substantially and also suggest a very important role for respiratory medicine in tying things up and ensuring continuity. And with those reflections on the way that we've looked at the data from Northwest London, I'd like to hand over to Nikki Smith, who's going to provide their perspective on the experience.
Thanks, Johnny. So hi everyone, I'm Nikki Smith and I'm part of the Patient Advisory Group of the LOCOMOTION study. I'm also a founding member of the charity Long COVID Support. I wanted to start by sharing how it's been working on this part of the study. If Dennis and Johnny had £1 every time I said to them, but how is this going to help people with long COVID? How is this going to improve care? They'd be very rich indeed by now. I wanted to make them constantly think about how this work could make a difference. After all, we know from patient experiences and the mountain of scientific evidence how serious long COVID is, including its impact on millions with the illness, their families and carers, the health service, workforce, and the economy to the extent of billions of pounds. That's this country. I've provided patient involvement on a few long COVID studies, and I find them all different with their approach to API. When it comes to this part of locomotion, myself and Rory, the other PAG member on this part of the study, have certainly been a part of the team. We've attended all the team meetings, been encouraged to provide input all the way through, and our voices have been listened to and acted on throughout. The work also reinforced how important it is to include in a patient advisory group patients who, besides their own individual experiences, have built a wider knowledge base across the condition, including through their network and research and knowledge they have accrued through their other work on the illness. For example, in this work, besides the UK genome codes, I was aware of international codes relating to COVID-19 and long COVID, and that these are actually visible to those in the UK. So I had a concern that some healthcare professionals may have inadvertently used international codes, and therefore studies just searching UK codes would be omitting vital data. So I sent the information to Johnny and Dennis. They searched for those codes, and as a result, they found a few hundred additional patients in the North West London records. My eye-opener for me, though, was in relation to how long it can take for researchers to be provided with the data they need. It was crazy how it took, and that caused major delays to the work being conducted. One of the most significant issues that's been highlighted in this work is the lack of appropriate coding in healthcare records. Post-viral sequelae are not unique to long COVID. They've been a well-known consequence of viruses for a long time, including SARS-1. So when SARS-CoV-2 hit, it was logical that there was a significant risk of ongoing symptoms. This raises a question of why was there a code for post-COVID issues ready to use in electronic health records from very early in the pandemic? Instead, SNOMED codes relating to long COVID were not brought into use until the end of 2020. By then, many people, including me, have been suffering serious ongoing symptoms since early that year and have been having healthcare interactions. In May 2020, having not recovered herself, Claire Hasty, another founding member of Long COVID Support, created a group on Facebook for people who were also experiencing these ongoing symptoms. And on 20th of May that year, Dr. Elisa Perego from Lombardy, sorry, my long COVID's kicking in, referred on Twitter to the ongoing symptoms as long COVID and the name stuck. Claire's Facebook group was subsequently renamed Long COVID Support Group. And by the beginning of August 2020, it had 15,000 members, and she spoke to the APPG on coronavirus. And many other people have shouting the alarm that they weren't recovering within the publicised 2 weeks and were very ill. So why the delay with implementing SNOMED codes? And why still the inconsistent and fairly low use of the codes? And why are SNOMED codes on COVID not set up to remain indefinitely on a patient's record until their GP knows the patient has fully recovered, instead of the code dropping off after a set period, typically without the GP actually knowing whether or not the patient is still ill? Perhaps this has been yet another harmful impact from the extensive gaslighting that has occurred over decades to people with other conditions caused by damage to the body by a virus, such as ME/CFS. COVID is not over. A large number of us still have life-changing COVID from the first wave, and who knows whether or not we're still coded as such in our healthcare records. Many people are still getting COVID and multiple times, and people are still suffering long COVID. Accurate healthcare data can make a vital difference. For example, by showing the scale of the issue, which in turn can have an impact on funding for healthcare and for research. To those experiencing long COVID, it can act as a reminder to their GPs that they are actually still ill, and when new treatments become available, those patients can be readily identified. It can help identify those who face additional challenges in obtaining healthcare. It can help identify those more at risk of developing long COVID, and thus help establish who should be offered prompt access to antivirals if infected or reinfected with COVID-19 and be offered free COVID vaccinations. And longer term, it will help research in tracking the health impact of long COVID over the following years, including development of other issues such as cardiovascular or neurological matters, and also any future implication of the SARS-CoV-2 virus in other conditions. After all, we know, for example, that Epstein-Barr has been associated with later development of sclerosis. So thank you, Johnny, Dennis, Brendan, and everyone else who's been working away on this part of locomotion with us. We know healthcare data is a crucial source of information, but it can be made much more powerful and have significantly more impact with accurate and up-to-date coding. So thank you.
Thank you, Nikki. I would say that Nikki has indeed been completely involved in all this work going forward. And I've put up in the chat a link to a paper in Environmental Research and Public Health, which was the systematic review of symptoms and signs and relationships with pathophysiology and potential causal mechanisms in long COVID that we did as part of this work to try and underpin what we were finding in the records. So thank you, Nikki, for your input into that systematic review. So that's we've seen part of that work. The other part, as I said, is published in the link there. And there's a fourth part which is still ongoing, and we hope to complete in the next 4 to 6 weeks, which is using machine learning to unpick this idea of what is it that makes someone get a long COVID diagnosis in their records, and what's the difference in the care pathways in the GP record between people with a long COVID diagnosis and those without, perhaps with similar conditions such as respiratory, cardiological, or musculoskeletal or mental health issues, using a deep learning model with transformers, which is the kind of the latest version of self-supervised machine learning. So that's a bit of extra work to come. We're just still building the model. So I've put open the questions there in the meeting chat. We've got a couple of comments, I think, rather than questions. The first quick question on codes. I think picking out the precise snow mode code is not hugely helpful. Dennis, if you wanted to go back to that slide with the different definitions, you'll find a code with the 4 text versions on it. None of them are long COVID, by the way. So Dennis, you could pop that up, and if anyone's interested, I think there's a number of patients on here. You can look in your record and there'll be a code. What you'll see is the text reference for the code rather than the numeric code. So you can take a quick screenshot of that. Do you want to pop that up? Johnny, you've got the slide, so yeah. So flick back to the one with the codes. I think it's early on. That's the one, yeah. So where it says data set, you've got chronic post-COVID syndrome, which is relatively new, ongoing symptomatic COVID-19, which is the nice UK definition for the first 3 months, and then post-acute COVID, which is the international one, and post-COVID syndrome, which is the first one, which is the nice definition in the UK, beyond 3 months of being unwell. So there's a big difference between the US definition, where you can have long COVID at 4 weeks, and the UK definition, where you've got to have it for 12 weeks before you meet the criteria. Okay, good. I've been picking up, Nikki, on what you were saying. I mean, you made some very interesting comments about future pandemics and use of terms and availability of recording things. I mean, I would say, perhaps in slight defense of that unfortunately the snow mode coding and what goes into the record is an international thing, and it really depends on the WHO to push for a new code and a new code to be adopted by the committee. So the things involving international committees and going into updated versions of things that go on a regular cycle take time, although they were released as a kind of urgent update to that. I think it's fair enough to say it was a long time for patients before that happened. I mean, there will be other pandemics, without doubt. We will go through this again, I'm sure. Hopefully not quite to the same extent, but one never knows. what would you say, I mean, if you were in front of the all-party parliamentary group again, what would you say in terms of preparation? What should we do apart from perhaps being quicker with codes? What else? What should we do for long COVID?
$1 million question. You've got to be prepared. I mean, we've known for a long time the risk of post-viral sequelae, and we've gone through this whole period again of patients not being believed. And there's been a total lack of public messaging from the government about it. That needed to be strong from the start, not only as a warning of the risks of the damage that COVID can do, but to sound the alarm of, you know, you really don't want to be getting this. Keep wearing your mask, keep taking preventative measures. All those measures have disappeared now in most healthcare settings.
Yeah.
There are lots of people with long COVID who are now going to their medical appointments, and they're the ones wearing the mask. Healthcare professionals aren't. Yet COVID's still rampant and the risk is still there. So it's that messaging right from the start that this is serious, and be prepared for people having those serious ongoing long-term conditions. I mean, many of us from the wave, it was, we're so ill, we're gonna die. I mean, it was horrific. And you spent so long fighting to be believed. That the whole messaging around it has got to be right from day one.
Thank you. Thank you. I'm keeping an eye out for questions with one eye, but I will continue to ask a few going across, keeping things interested. Dennis, I was particularly struck by the slide you had, which showed people moving across to have new diagnoses of these clusters of long-term conditions. Mm-hmm. These new, particularly diabetes, and I think mental health and diabetes was the obvious one that struck out.
Yeah,
these are new diagnoses, aren't they?
Yeah, all new, all developed after infection. So.
Okay. I mean, this is UK support for work that's being done, and to some extent disbelieved to a large extent, by the Veterans Administration in the US, where they've persistently highlighted the risks of developing new conditions, particularly autoimmune conditions, type 2 diabetes, hypothyroidism, cognitive issues, cardiological issues, ischemic heart disease. And I think that's really very interesting. I mean, Johnny, you're very much the skeptic in this group, and you keep on reminding us, you know, obviously apart from you know, association is not causality, but the robustness of the data, given the introduction that you had. To what extent do you think you can say, well, this is believable when you've got other data from other countries which suggests similar things? Does it have more weight?
It adds more weight conditional upon those other things not being similarly limited. Yeah. So there is a danger that we're all working on data that are similarly limited to only those who've managed to get a long COVID diagnosis, for example, and then we end up perpetuating something that might not be necessarily a faithful telling of what's really going on. However, I was reassured to see that lots of the findings that we get from the work that Dennis shared align with one of the large surveys from the US of about 20,000 people with long COVID from across millions within the US that show similar relationships with respect to age and also socioeconomic deprivation to those that we found in our analysis. So there's a little bit of opportunity for corroboration there when they come from quite different methods. So yes, I think there's always going to be concerns about the underlying quality of the data here because of the problems that Nikki talked about, yeah, and that I introduced. That we can't really do anything about that because the data don't exist for us to do so well. But we are seeing some encouraging alignments that give us some confidence in our findings.
Okay. Yeah, I mean, I've been in meetings where there's been a lot of discussion around the VA data in particular. I think the biggest criticism of that, and probably applies to us as well, is that you've got a big effect of people engaging with healthcare more. You know, there's I think it's been in the news recently, the number of people with undiagnosed diabetes in the country. So the fact you go along with symptoms to your GP makes you more likely to be diagnosed with diabetes, regardless of whether there's an association or not. Yeah, it's you know, what sort of studies should we be doing then? You know, it's really tricky to think our way through this.
Yeah, definitely. And I think trying to use as many different methods as you can is good. And we've seen interesting work with these long survey studies that have been done iteratively by the ONS and in the US that provide really useful resources that are different to the work that we've presented, where we've looked at electronic health record data specifically. But none are going to get us. We'll never know the true prevalence in the population of long COVID.
Yeah.
That's,
I mean, it's a classic
something
example of a symptom pyramid, isn't it? Yeah, I think all GPs, I'm a GP, by the way, we're very familiar with this, and we learn it from sort of day one of General Practice 101. In that, you know, if you survey symptoms in the community, you get a lot of illness and symptomatology, and then you have people consulting their GP and people with a diagnosis and people under specialist care from just very narrow pyramid at the top. And I think the mismatch between what goes in the records and what people say they have applies here. It's partly an explanation for that. And it must, I think, to some extent, must certainly have been influenced by, if not the actuality, but certainly the very strong public perception that access to GPs was very limited during, particularly the first year and a half or so of the pandemic. And the tremendous heterogeneity that GPs have in their interest in long COVID. And there's a comment there from Grant in the group. So I run a long COVID peer group. Feedback about the lack of GPs who want to acknowledge it or can deal with it constructively is concern. Even GPs telling our members long COVID is now over. Great. There is also reluctance to label people with long COVID and ME/CFS because of the overlap, and it makes it difficult to get a proper diagnosis. I'll tackle that one actually from a clinical perspective, because I think it is interesting to bring this in. I'm a GP 1 day a week. I'm a partner in my practice, and I took a strong and personally led interest actually in long COVID right from the very beginning, because I was quite unwell through most of 2020, in fact, and I was saying to my colleagues, you really need to be looking out for patients who are continuing to have symptoms after COVID, not only because we haven't really talked about it here because it doesn't show up in the data. Serious illness does occur in patients who get misdiagnosed with long COVID, or it gets put down to the long COVID symptoms. Actually, there's serious stuff going on of other nature, but also that they absolutely need to be validated and taken seriously. And then we started to see, patients who paid to have investigations elsewhere, usually in the private sector in London, were coming back with diagnoses of mast cell problems, postural orthostatic tachycardia syndrome, POTS. Now, I'm sure all the patients on this group know that very well, but I think discovering the true extent of POTS within patients with the label of long COVID is probably one of the lasting contributions of the LOCOMOTION study, because it was a subject of great debate amongst the different clinics. And you'll have seen on a previous webinar, was one up on the series, that there's a paper out, that actually 10% of patients with a diagnosis of long COVID in a long COVID clinic meet the definition, the consensus definition for postural orthostatic tachycardia syndrome. That's treatable, potentially, or at least ameliorable by various treatments. And really it's down to GPs to recognise that and screen patients for it. The long COVID ME/CFS overlap is quite interesting. We haven't looked at ME/CFS, I think, as a because it would be very small numbers. But I bet if you went back into the Northwest London data now, there'd be quite a lot of people with long COVID who've had it for a while who'd be diagnosed with ME/CFS, because again, it's a criterion-based diagnosis, principally on lasting fatigue and post-exertional symptom exacerbation. And I'm personally am very keen on dual coding patients with that, because I think if they meet the criteria, they meet the criteria. It's very straightforward. Nikki, some thoughts on that? Yes, muted. Muted.
How long have we been doing this? Still talk when I'm muted. And now I'm trying to remember what I was going to say. Oh yeah, diagnosis in long COVID it's sometimes a double-edged sword though, because we're finding anecdotally from lots of people in the patient support groups and on social media that if they go to the GP and need referrals, if there's mention of long COVID in that referral letter, people are experiencing their referrals being accepted, whereas if the letter is just dealing with symptoms, people are more often than not getting accepted by the referrals. So as much as people may want a diagnosis, or they feel maybe a bit relief when they've actually got a diagnosis of long COVID or ME/CFS on their record, because that is explaining, an explanation of why you're feeling damn awful. Sometimes in the medical world, having that diagnosis written down doesn't always help with care. And it's exhausting as a patient. So many of us are having to advocate for our own care and push, or having to coordinate it because it can be so fragmented, having to go from hospital to hospital. Yeah, it's absolutely shattering as a patient having to deal with it.
I think, I certainly concur with that, and also I think very much the work that Johnny was presenting around having across different patients, different providers, because you will find, you've got the certain flavors that you see clinically in long COVID patients. You've got the long haulers, if you like. Perhaps I could talk about that group for a moment. People who are unwell, have been unwell for 3 years, more. They're now a very specific, very severe group of people. There are some with more cardiological things, chest pain and severe fatigue, sort of severe ME/CFS type things. There's people with sort of polyneuropathy, peripheral neuropathy, numbness, tingling, pain, overlaps with fibromyalgia, but very severe, much more so than you would normally expect on that. And trying to find a place who would accept those patients, knowing full well from their service that this is a patient who will need a lot of ongoing care. It's very hard to do that, because these are often tertiary referral services or regional referral services with very strict criteria which haven't been considered of long COVID at all in their population. So trying to persuade Stanmore, for example, a patient with severe mobility issues relating to their long COVID, to be assessed from that perspective for a rehab. Very, very challenging. Okay, let's go back to a couple of questions here. Is there a way to ask health providers, primary or secondary, to flag up people with ongoing long COVID symptoms now with a common code? So that's a question for, should we have another code for people who are perhaps these really long? They fit in the UK criteria. They fit within the definition. Now, what Nikki was saying, I think, was quite interesting. And I brought this up, that within your GP's health record system, when you enter a condition, you get a choice as to how long that should stay in the records. And there are certain defaults put in there. So if you put UTI, or upper respiratory infection, it'll drop off after a week from the problem list. If you put diabetes in the problem list, it stays on indefinitely. For some reason, long COVID drops off after a year. So if you look at people's problem lists, unless you've re-entered it, it won't be on there. So I think that's something for patients to be aware of. It doesn't affect the data here because we're just looking at the index date. That's what John's shaking his head there. Okay, Grant again. Okay, yes, group with long COVID, ME/CFS, lots of people with both. Waiting time area for ME/CFS is more than 18 weeks. Primary care assessment services area is great, but they're not permitted to discuss ME/CFS. Okay. Yeah, I mean, I know Manoj's view, my co-chief investigator, is that these are probably part and parcel of the same sort of thing. And the ME/CFS is largely a post-viral problem, and long COVID is another post-viral problem. That's not to say they are exactly the same thing, and they're not. They're different definitions, but they have a similar cause. So I would recommend people to have a look in the paper I posted up, because we've got a diagram there about all the possible ways in which the symptoms and potential causal mechanisms for long COVID could relate, and it's a nest. You know, it's an complex web rather than a simple linear relationship with things. And I think that makes it very difficult with things. Johnny, I'm going to bounce a final question at you. I know we're slightly 1 minute over time, but I think it's interesting. If you were in a hypothetical advisory role to another future government about future pandemics, what would you say to them about what we could practically do in terms of setting up surveillance and things for potential future pandemics? What would your ask be, or recommendation be?
So I think there's always, as Nikki was saying, and you were saying, Brendan, there's going to be another pandemic in some way, shape, or form, but we don't necessarily know what the host of organism is going to be. We don't know what the associated long-term conditions arising from that infection will be, and therefore planning something too tightly is potentially counterproductive, in the sense that so much of what was done around COVID was planned around influenza, and therefore because you had your planning mechanisms in place, you ended up being wrong-footed by being a different pathogen to the one you were expecting. So I think having something in place that is built around being responsive. So the fact that it takes a year for codes to appear and be meaningfully used is far too long. The inability to rapidly, retrospectively record diagnoses is wrong. And understanding that long-term sequelae are likely from viral and non-viral pathogens operating at scale within a community is going to create a significant population health burden. Having a means of surveillance to identify that as quickly as possible, and trying to think about, in various scenarios, what you would spin up as a means of delivering a chronic care service, or as a service for people who have long-term sequelae that come from that. Should it be through whichever specialty in secondary care most neatly maps onto it, as is the case for respiratory medicine in the case of long COVID, at least in Northwest London? Should it be something that comes from primary care? Should it be something for which there's sort of a pot of core funding already earmarked that just gets rolled out? I think that sort of responsiveness, rather than necessarily trying to tailor things too closely, is probably what I would recommend, because a year is too long.
Yeah.
I mean, we're seeing from the data, there are lots of things that we will never know, that we should know, that a year of poor data recording has meant that we can't achieve.
Yeah, absolutely. There's a comment from Mike Omerod there, which I think goes along with that. He's mentioned machine learning, evaluating emerging patterns in data, and continual analysis. I think yes, absolutely. Part of government should be doing that.
Although the machine learning is only as good as the data it's fed.
Yeah, and the comment I was going to say.
Yeah, sorry.
On the back of that, yes, I agree. The huge, I mean, the proverbial sort of elephant in the corner of the room here is that a lot of this stuff is there in free text. It's tremendously rich, and we have the capability now with large language models to analyze large amounts of free text. Operating in a secure environment with privacy protection, a large language model monitoring the free text of what's going into electronic health records could not only shed enormous light on the relationships of symptoms, could flag up far earlier things are going on. And I think that's perfectly doable from a technical point of view. It's just a political, social, ethical permissions agreement from everybody in society. This would be a useful thing to do. Okay, good. Thank you, everybody. We're slightly over time, but I think we waited a minute. And thanks for the audience, and hopefully that will make a useful thing for people to view up on the internet afterwards. So thanks for all the presenters, and thank you for our people who watched. Thank you. Bye-bye.
Thank you very much.
Bye.
Thank you.